Thank you, ma'am. So I will be discussing the basic part, that is science of angiopoietin 2 in neovascular AMD and diabetic macular edema. So I don't have any financial interest to start with. Now, the complications from diabetes mellitus like diabetic macular edema, tractional retinal detachment, and vitreous hemorrhage, they are the leading causes of preventable vision loss in working age patients. And vascular endothelial growth factor, it plays a pivotal role in the pathogenesis of these complications. Therefore, anti-VGF, that is VGF inhibitors, are the cornerstone in their management. Now, monotherapy anti-VGF, they are quite effective but burdensome treatment. Because of the transient response which they have, the patient needs multiple injections and it becomes burdensome for the patient. Even after adequate treatment, few of the patients, they land up with persistent diabetic macular edema, and it is reported to be along 30 to 60% depending upon the VGF, anti-VGFs which we have used. And even despite treatment, further patient progress to vitreous hemorrhage and tractional retinal detachment. This clearly indicates that there is some other molecular pathway involved in the pathogenesis. So the other molecular pathway, one of them which is very potent in the pathogenesis, has been discussed here, that is angiopoietin tyrosine kinase signaling pathway. Now, if we look into the retinal vasculature, it is divided into the inner retina and the outer retina. The inner retina receives its supply from the retinal vasculature, while the outer retina receives the supply from the choroidal vasculature, as we all know. Now, the retinal vasculature, it is comprised of the endothelial cells which are surrounded by much of pericytes. There are abundant pericytes surrounding the endothelial cells, and along with that, there are glial cells which will form the inner blood-retinal barrier. While the choroidal vasculature, it is quite permeable. They are fenestrated endothelial cells. They have fewer pericytes. Now, the main pathology which affects the retinal vasculature is the diabetic retinopathy, while the pathology which involves the choroidal vasculature is the neovascular AMD. In both of these conditions, there is destabilization of the mature vasculature which is there. Now, angiopoietin, they are a family of growth factors which act on endothelial cell receptor tyrosine kinase. Now, there are two main potent angiopoietins which are there, angiopoietin 1 and angiopoietin 2. Angiopoietin 1 maintains the normal homeostasis and the vascular function. So here we can see it is released by the platelets and the pericytes which are surrounding the endothelial cells. It acts on the endothelial cell receptor tyrosine kinase and initiates the signaling. It also blocks the VGF receptor. Therefore, that is, it down-regulates the VGF receptors. Therefore, the responsiveness of VGF-A to its receptor is also reduced. So, it is not just acting on the tyrosine kinase receptor, it is also reducing the responsiveness of VGF to the VGF receptor. Now, here we can see it increases the adherence junction. So, between the endothelial cells, it increases the junction. So they are tightly packed and prevents the vascular permeability. The vascular permeability is reduced. So angiopoietin 1 we are right now talking about, it maintains the normal homeostasis. It increases the adherence junctions and reduces the responsiveness to VGF receptor of VGF-A. Along with that, it increases the pericyte recruitment which is there along the vessel wall. Therefore, again, the leukocyte migration will be reduced, preventing the inflammation. So here we can see it keeps the free-flowing leukocytes. The leukocytes, they do not adhere to the vessel wall and they do not leak out into the extracellular matrix, preventing inflammation. Therefore, angiopoietin 1 tyrosine 2 signaling pathway, which maintains the normal vascular function, it leads to the non-proliferative, anti-inflammatory and the non-angiogenic state of the healthy blood vessel. Now, what about angiopoietin 2? Angiopoietin 2, they lie in the Weber palette bodies. How are they formed? They are formed by the polymerization of the von Willebrand factor. So they lie in these Weber palette bodies in normal homeostatic condition. When do they get released and how do they act? So the main stimuli which causes the release of angiopoietin 2 is hyperglycemia and hypoxia, which usually happens in our diabetic patients and neovascular AMD patients. So once there is hypoxia and hyperglycemia, angiopoietin 2 is released. Now, angiopoietin 1 and 2, they both act on the same receptor, tyrosine kinase. Now, once angiopoietin 2 concentration increases, the signaling of angiopoietin 1 to tyrosine kinase is reduced. Therefore, all the effects of homeostasis of the vascular function maintenance till now, what we have seen, will be reverted now. Let's see how. Now, it will act on this receptor and the signaling pathway will be blocked. Now they will increase the responsiveness of VGF receptor to VGF. Therefore, the effect of VGF will be now much more when the angiopoietin 2 is released. This leads to loss of pericyte coverage and disruption of basement membrane, leading to vessel destabilization. It also keeps the adherence, it increases the adhesion of the leukocytes to the basement membrane, and therefore leukocytes, they adhere and they try to transmigrate into the extracellular matrix, leading to inflammation. It promotes the sprouting of new vessels, leading to angiogenesis. So, in addition, angiopoietin 2 along with VGF, they have a synergistic effect. So, VGF itself is acting, angiopoietin 2 is itself acting, and they both have a synergistic effect. Therefore, the angiogenesis and the vascular instability is much more increased. Therefore, we have a molecule faricimab which acts on both VGF-A and angiopoietin 2. Now, why do we need to have a molecule, bispecific molecule, which will act against both these two? As I told you, there is not only VGF which is involved in the pathogenesis, there are many other molecular pathways, and one of the very important molecular pathways is angiopoietin 2. Now, there are clinical and preclinical trials which are supporting that the bispecific antibody is much more effective compared to the only anti-VGF and only anti-angiopoietin 2 effect. Let's see. Now, here is a clinical relevance to this. Now, when we see that in cases of AMD, retinal vascular occlusion, diabetic retinopathy, and proliferative diabetic retinopathy, the concentration of angiopoietin 2 in the vitreous is much more higher compared to the control group. So, when there is hyperglycemia and hypoxia, the angiopoietin 2 levels are increasing. Now, preclinical trials are also supporting this. Now, here we can see that we have induced vascular leakage by injecting VGF in the mice, and now we have a mice which is angiopoietin 2 deficient. Now, we can see that the vascular leakage is much less when the angiopoietin 2 is deficient in the mice compared to when the angiopoietin 2 was present. So, this is showing the synergistic effect which VGF has to angiopoietin 2. Now, the macrophage infiltration is also reduced. Now, macrophage infiltration is reduced by only anti-VGF and only anti-angiopoietin 2 also. So, anti-VGF, they reduce to 39% macrophage infiltration. Anti-angiopoietin 2, it reduces to 33%. But both these numbers were not statistically significant. While the combined molecule, the bispecific anti-angiopoietin 2 and VGF, it has reduced to almost 54%, which is statistically significant. Similar is the leukocyte transmigration. So here the lipopolysaccharide was injected into the mice and then leukocyte transmigration was seen. It is much less with the bispecific molecule compared to the monospecific therapy. Similar is the tumoral neovascular growth and pericyte coverage. So breast tumor cells were injected into the mice models, and then following that the anti-VGF and anti-angiopoietin 2 were injected, followed by the bispecific molecule. The reduction of tumor new vessel is much more with the bispecific antibody compared to the monospecific one. Now, this was all about the vascular permeability and inflammatory effect. So here we will see in neovascular AMD. So here the laser-induced CNVM was induced in the mice models. 9 lesions were induced, and then following that the FFA was done. At 2 weeks, the injections were given to the mice, anti-VGF, anti-angiopoietin 2 and anti-angiopoietin 2 and VGF combined. Here we can see that the leakage is much less with the bispecific molecule, although it is reduced with more with VGF, anti-VGF than anti-angiopoietin 2, but the combined effect, you can see here that there is no leakage after 2 weeks of injecting the bispecific molecule. So as I told you, the dual pathway, they have a synergistic effect. So blocking the both will help us in playing the interplay which is happening in the pathogenesis of neovascular AMD, DME, and the retinal vascular occlusion. So I will explain this with 2 examples which I have the cases with me. So here is a patient who is a 58-year-old male diabetic hypertensive presented to me when the patient in the superior temporal BRVO is there. So here we can see the OCT. This patient presented after receiving 2 intravitreal ranibizumab and 5 Ozurdex. So after the first and second Ozurdex, the response was good. The patient was not responding much to the ranibizumab. But after third, fourth, and fifth Ozurdex, that is, even our patient is not responding to steroid. So at this stage, we discussed with the patient and shifted the patient to ferricimab. So after first injection itself, we can see the dramatic response, and after second injection, the CME has completely resolved and patient has gained vision of 6 part, which patient was not able to achieve over last 2 years. Similar is this case of inferotemporal BRVO. Here we can see drill is present at the fovea and chronic cystic spaces which are there in the outer nuclear layer. So this patient also received 3 intravitreal razumab and 2 intravitreal Ozurdex. Patient has not responded to any of the drugs till now. The neurosensory detachment used to reduce with the dexamethasone implant, but the chronic cystic spaces and the disorganized layer, that was not getting reduced. So we shifted this patient also to intravitreal Vabysmo. So after one injection, although I cannot see anatomically much significant improvement, but patient was feeling symptomatically much better. Here we can see what the drill was present at the fovea, that has little bit improved, although the cystic spaces did not improve much. So I discussed with the patient that let's try the second injection also. Patient was billing for the same because he had a symptomatic improvement. After second injection, the cystic spaces were markedly resolved, and only after 2 injections now patient is has not received after second the third one, but patient is maintaining his visual acuity of 6-9 parts since last 3 months with only 2 ferricimab injections. Thank you.
Thank you, Dr. Megha, for elucidating the molecular basis of the 2-pathway suppression that we have with this new drug, faricimab. I think it was very clear to us from the early days that there was something lacking in what we were doing when we were giving anti-VEGF injections, because some patients responded and some patients did not. And although there have been a lot of studies about the level of anti-VEGF and the OCT biomarkers, we still could not put a finger to why some patients respond and some patients do not. And it was always known that there are a lot of pathways acting other than VEGF pathway. And when this came out, when the details about this drug came out, then it was clear that at least one more pathway is being inhibited, and hopefully we will have better results than what we had before. So I think that has been our experience also with the drug. So we will go more into the clinical findings and how this drug has impacted our